Hi everyone, I'm Dr. Rahil here. Welcome to another cardiology topic. Today we will discuss diagnosis and management of heart failure. Let's first start with a case scenario. A 79 years old lady was brought to emergency department by ambulance who woke up from sleep with severe shortness of breath and cough productive of pinkish frothy sputum. She was otherwise well before going to bed. Her significant past medical history included hypertension and type 2 diabetes. On examination, she was tachypneic and was unable to speak in full sentences. Other significant findings on physical examination included tachycardia with heart rate of 120 beats per minute, blood pressure of 178 over 90 millimeter of mercury. On lung auscultation, there were generalized crepitations bilaterally with decreased oxygen saturation of 88% on room air. She was afebrile. Her ECG revealed sinus tachycardia. There were no significant STT changes. Her chest X-ray showed bilateral alveolar shadowing and the findings were consistent of pulmonary edema. Now coming to the question, what is the most appropriate initial treatment in this situation? Please pause the video to go through the options and answer the question. The correct answer is option 3, which is intravenous furosemide. And this takes us to the discussion of heart failure in detail. I will revisit the scenario later to discuss about various options in management of heart failure. This presentation is mostly based on NICE guidelines on acute heart failure, which was last updated in November 2021. I have also consulted heart failure management guidelines from European Society of Cardiology, as well as other great resources such as uptodate.com and BMJ Best Evidence website. Without further ado, let's start with the definition. Simple definition of heart failure is it is a condition in which the heart does not pump enough blood to meet all the needs of the body. Acute heart failure can present as new onset heart failure in people without known cardiac dysfunction or as acute decompensation of chronic heart failure. It can result from an abnormality of cardiac structure or its function. Most important causes of acute heart failure are number 1, acute coronary syndrome, number 2, hypertensive emergency, and number 3, tachyarrhythmias or severe bradycardia or conduction disturbance. Other causes include acute mechanical cause like ruptured interventricular septum or acute mitral regurgitation as a complication of acute coronary syndrome, acute pulmonary embolism, infections including myocarditis and cardiac tamponade. Clinical features. The onset and severity of symptoms of acute heart failure vary and depend on the nature of the underlying cardiac cause and the rate at which the syndrome develops. Patients typically present with sudden onset of shortness of breath and overwhelming sensation of suffocation and air hunger. The other symptoms are cough, expectoration of pink frothy sputum, sensation of drowning and extreme anxiety. The physical examination findings are tachypnea. Patients will be sitting upright using accessory muscles of respiration and unable to speak in full sentences. Tachycardia. The pulse rate is most often elevated secondary to an increased adrenergic drive. Blood pressure is markedly elevated if acute heart failure is secondary to hypertensive emergency. It may be low in presence of acute coronary syndrome and cardiac arrhythmias. The oxygen saturation is usually less than 90% on room air before treatment. Auscultation of the lungs reveal coarse crepitations with V's that are detected first at the lung bases but then extend upward to the apices as the pulmonary edema worsens. Cardiac auscultation may be difficult in the acute situation, but third and fourth heart sounds may be present. Now let's discuss the investigations. ECG. Every patient presenting with symptoms of heart failure should have ECG performed as soon as possible. It may reveal the evidence of ischemia or infarction, arrhythmias, or evidence of left ventricular hypertrophy, usually seen in patients with diastolic heart failure. Chest X-ray. Common findings on chest X-ray include increased alveolar markings due to accumulation of fluid in the alveoli, fluid in the horizontal fissure, and blunting of costophrenic angles. Other findings may be presence of cardiomegaly and upper lobe diversion, which are basically prominent upper lobe pulmonary vessels. Chest X-ray is also useful to rule out alternate diagnoses like pneumonia. Natriuretic peptide. NICE guidelines suggest to perform a single measurement of serum natriuretic peptide like BNP or NT-proBNP in people presenting with new suspected acute heart failure. Diagnosis of heart failure is ruled out if BNP is less than 100 nanogram per liter or NT-proBNP is less than 300 nanogram per liter. However, elevated levels of natriuretic peptide do not automatically confirm the diagnosis of acute heart failure, as they may be associated with a wide variety of cardiac and non-cardiac causes. Routine blood tests, including urea and electrolytes, troponin, especially if there is evidence of ischemia or infarction on ECG, and D-dimers if suspicion of pulmonary embolism. Echocardiography. Echocardiography is used to assess myocardial systolic and diastolic function of both left and right ventricles, valvular function, and measurement of left ventricular ejection fraction. Any patient with suspected heart failure who is hemodynamically unstable or in respiratory failure should have immediate bedside echocardiography. If a patient is stable, echocardiography should be performed within 48 hours. Coming to management, oxygen therapy should be titrated to achieve oxygen saturation of 94 to 98%. Nitrates. Nitrates in the form of sublingual GTN or intravenous form as isosorbide dinitrate used to be part of initial therapy, but current NICE guidelines suggest not to use nitrates routinely and to consider only in specific circumstances with close monitoring of blood pressure for people with concomitant myocardial ischemia, severe hypertension, or aortic or mitral valve regurgitation. Diuretics. Diuretics are the mainstay of treatment. Loop diuretics like furosemide is the first choice. It can be given as intravenous bolus or as infusion. NICE guidelines does not give a specific recommendation about dosage, but 40 mg intravenous bolus is the optimum initial therapy. Adjust the dose according to the patient's response and clinical status. If a patient is already taking a diuretic, we should consider a higher dose, and some experts recommend to use twice the equivalent of oral dose unless there is evidence of patient's non-compliance with the therapy. Ionotropes and Vasopressor. Patients with acute heart failure with potentially reversible cardiogenic shock should be treated with ionotropes and vasopressors and should be admitted in a coronary care unit or ITU. Discussion of individual drugs in this situation is beyond the scope of this presentation. Ventilation. A person with cardiogenic pulmonary edema with severe dyspnea and acidemia should be considered for non-invasive ventilation such as CPAP or BiPAP without delay. Consider ventilation in people with acute heart failure that despite treatment is leading to or is complicated by respiratory failure or reduced consciousness or physical exhaustion. And the last but not the least is the management of underlying cause of cardiac failure simultaneously with the other management strategies we have discussed just now. Let's do the summary now. Heart failure is defined as inability of the heart to pump the blood to meet all the needs of the body. Although there are many causes of heart failure, the most important causes are acute coronary syndrome, hypertensive emergencies, and arrhythmias. Clinical features of acute heart failure include sudden onset of severe shortness of breath associated with decreased oxygen saturation and presence of crepitations on lung auscultation. Most important initial investigation is ECG, which may reveal underlying cause of heart failure such as ACS or cardiac arrhythmias. Chest X-ray helps to confirm the diagnosis of heart failure and rule out alternate diagnoses such as pneumonia, etc. Elevated level of BNP is seen in many cardiac and non-cardiac causes, but normal levels in the setting of acute presentation of shortness of breath rules out the possibility of heart failure, and NICE guidelines recommend to perform single measurement at baseline. Apart from routine blood tests, other investigations include troponin if suspicion of ischemia or infarction. In fact, European Society of Cardiology guidelines suggest to perform troponin in every patient with acute heart failure, as elevated troponin level is a poor prognostic marker. Echocardiography helps to evaluate the structure of heart, valvular disease, and ejection fraction. Treatment of underlying cause of heart failure is an important aspect of management and should continue simultaneously to other treatment options. Mainstay of management of acute heart failure is diuretic therapy, the first choice being furosemide. Nitrates should only be used in specific situations such as management of severe hypertension with close blood pressure monitoring. Ventilation such as CPAP or BiPAP is indicated in presence of acute heart failure with acidemia. Mechanical ventilation is indicated in patients with reduced level of consciousness or physical exhaustion in presence of reversible underlying factors. Ionotropes and vasopressors are indicated in presence of cardiogenic shock. This is the end of this presentation. Thank you for watching. The next topic is on hypertension. Till then, take care and goodbye.